Okay, welcome to the Auditory Learner. This is going to be the recording for Cariology and occlusion, and it's going to be involving Caries process and the um, dental trauma lecture. Okay, so let's get right into it. So beginning with the Caries process, that the caries is the process, and then that ultimately results in the cavity. So the cavity is the hole, and the Latin meaning for cavity or caries is rottenness. So ancient men's caries were usually found on the CEJ or the cementum, and then modern men's caries are now found on the grooves and fissures. There's four factors total that are the principal factors for caries. The fourth one is time, but the first three are the principal ones, which are the host, the microorganism, and the substrate. So the host is the saliva and the tooth, which is difficult to study, the microorganisms, and then the substrate, which is the diet. And like I said, the fourth one is the time. The caries process requires a susceptible host, a cariogenic flora, and a suitable substrate over a sufficient length of time. All right. Next thing that we're going to talk about here is the demineralization and the remineralization process. All right, so the bacterial metabolism is what produces the byproducts, the acidic byproducts, which then cause demineralization. So demineralization alternates with remineralization, and that is an ongoing dynamic process, which is the issue, and it must be balanced. So what we need to understand here is that Streptococcus mutans, that is the bacterial species that begins, which is considered to be the major species in the caries process and is found in large numbers in biofilm over smooth surface lesions. It requires a solid and smooth surface for colonizations. So Streptococcus mutans is the one that metabolizes sugars and produces lactic acid, which causes the most damage. After the lesion develops, and then it's lactobacilli that becomes the main species in the process, which decreases pH levels to the critical pH level of 5.5 to 5.0. That is a lower pH level that leaches um, calcium and phosphate from the enamel. So when we get to 5.5 to 5.0, that's the critical level. Okay, and again, it the species that first begins the caries process is Streptococcus mutans, and then the second one after the lesion develops, it's Lactobacilli, which drops the pH level in the mouth. Again, and that leaches calcium and phosphate from the enamel. Um, and then a side note, Coca-Cola is 3.5 in the pH scale. Then when it comes to the formation of a lesion, what we need to understand here is that it doesn't happen all at once and it can take several months. But when the pH drops and it dissolves things in this order. So the first thing that's going to dissolve when the pH drops is calcium fluoride, or CaF2. After that, it's going to be hydroxyapatite, or HAP. And then the last thing to dissolve is going to be the fluorohydroxyapatite, FHA. Okay. Um, but when the pH elevates, all right, crystals reform from the pool of dissolved ions, some as hydroxyapatite, HAP, then FHA, and then finally calcium fluoride, which would be the last thing when it elevates. But it's the first thing to go when the pH starts dissolving. Um, the speed of a lesion can be chronic, usually 6 to 24 months, and affects the general public more than institutionalized individuals. All right. Um, also, the longer that sugar remains on the tooth, it increases the risk. So it depends a lot on the frequency of eating sugars, direct and consistent relationship between the frequency and prevalence. Um, let's talk about terms of caries categories. All right, here we have preclinical white spots. This means that there's no cavitation, can be remineralized. We have active caries. We have arrested caries, which means dark lines. And if you see a dark line, that means that the process was ongoing at one point. There's treated caries. There's caries on crowns of teeth. There's root caries. Side note, patient needs to see the dentist at least once per year by law. So I believe this conversation was being had because sometimes the patient is doing so well with the hygienist that the hygienist doesn't see anything, and so that doesn't require a patient to see the dentist, but the dentist by law needs to see the patient even if nothing's going on once a year. Anyways, back to terms of caries categories. Incipient caries are just the beginning at the enamel surface on the x-ray, and they're non-cavitated. Moderate caries are approaching the dentin on the x-ray. Advanced caries are is a radiolucency in covering enamel and the dentin already. Then you have severe caries where it's 2 millimeters or less of radiolucency to the pulp, and absolutely no ITR on those. Make sure we use the other Explorer except for the ODU one. The ODU is not for calculus. 40 to 76% of carious lesions in adults are arrested. 55.9% of adults over 75 experience root caries. And then men experience root caries more than women, 1 to 2 or 2.5 times. Okay, root caries. Root caries. Factors that affect root caries are age, periodontal history, medications, neglect, and even things like Parkinson's disease. Usually gingiva follows the bone. Periodontal surgery may also increase the risk of root caries. Lesions are not cavitated unless it is noticed, and then it tends to spread laterally. So root caries are usually 0.5 millimeter to 1 millimeter in depth with a dark brown appearance. That is the root caries. Let's talk about what's going to be on the exam here. So there's 3 primary stages of caries process. All right. These 3 stages are called the initial stage, the second stage, and the development overt cavitation stage. The initial stage is when an incipient lesion and it is reversible because of the surface change. There is an ion deficit here in the initial stage where micropores develop and can be clinically seen as a white spot, but it's not always radiographic. You must reduce lactobacilli and streptomucoccans to arrest caries in the initial stage. On the second stage is demineralization towards the dentino-enamel junction. It is still reversible. That is all there was for this second stage towards the DEJ. So meaning it hasn't really penetrated the dentin yet. Development of the third stage, which is the development of overt cavitation. This is irreversible. Here, there's a destruction of enamel matrix due to longer exposures and lower pH levels, and there's a bacterial invasion. So remember those 3 primary stages. There's initial stage, there's a second stage, and the development of overt cavitation stage. The first stage, initial stage, is reversible. Second stage, still reversible. Third stage is not reversible. Contributing factors are disease occurs when challenge exceeds the body's capacity for defense and repair. It's just like occlusal trauma. Those are the contributing factors. Okay. Composition of enamel. is 96% inorganic matter with 3% water. It is more mineralized than bone and dentin because crystals like hydroxyapatite calcium and phosphate and hydroxyl. So the length of enamel cap is 1 to 3 millimeters, and the units are the rods and prisms. Between each rod is a protein matrix. And remember that the outer enamel is stronger and more resistant to caries than the inner enamel. So that means there's 2 layers of enamel there. So then we have composition of dentin, which is 70% inorganic matter with 30% water. And then we have cementum, which is the lowest inorganic material, that's 45, with 55% organic. All right, let's talk about the 4 general areas of where caries begins to form. That is going to be in pit and fissures and smooth surfaces, root surfaces, and on recurrent or secondary surfaces. All right. The next very important thing that we need to understand here are the primary dentition caries incidence. This is going to be on the exam, as stated very explicitly by professor. So primary dentition caries incidence. This means that the teeth on the deciduous teeth that have the highest susceptibility to decay on primary or deciduous teeth. So we're going to begin by going from the very first all the way to the fourth, meaning that there's a hierarchical order here. And we're going to start with the most common one down to the least common. So on primary teeth, the most common tooth that gets caries is going to be the second molar. Again, on a primary dentition, the second molar is basically the last molar. Okay. So the second molar. Then the second most common tooth to get decay is the first molar. So you're talking about the last tooth, then the second to last teeth. So the last teeth are the first ones, or the highest incidence. Second to last teeth are the second to highest incidence. Okay, there's an inverse relationship. So the first is the second, and the second is the first. Then the third are the cuspids, meaning the canines. All right, just like, and a good way to remember that is that on a baby teeth, the third tooth, if they're all erupted, is the canine. That's a good way to remember that. And then the fourth are the incisors. So you can almost say that it is in the sequence starting from the back to the front. So second molars are the furthest back, first molars are the second to last, cuspids are the third to last, and then incisors are the fourth to last. All right, so that should be pretty good. Again, there are no premolars in deciduous or baby teeth dentition, okay? Now let's talk about permanent dentition incidence. So this is the same thing we just talked about, but this time we're going to talk about permanent teeth this time. All right, this is a little bit different. So the first tooth with the highest incidence for caries is going to be the mandibular first molars. Okay, so the lower first, meaning number 30 or number 19. Those are the highest incidence for decay. The second incidence for decay are the maxillary first molars. So that's going to be teeth number 3 and number 14. Those are the second highest incidence for decay. The third highest incidence for decay is going to be the maxillary and mandibular second molars. So this could be teeth number 31, tooth number 18, okay, tooth number 2, and tooth number 15. Okay, the fourth highest incidence for caries dentition Caries dentition is the second premolars. All right, the second premolar is the one right next to the first molar. The fifth highest one is the maxillary incisors. Okay, so that could be the front teeth. Okay. The sixth highest is the maxillary, is the premolars. The first premolars. Seventh highest is the mandibular incisors. And the eighth highest are the cuspids. So the cuspids, meaning your canines, are the least susceptible. All right, so let's just review that one more time. Primary dentition caries incidence for baby teeth. The first highest is the second molars. The second highest is the first molars. The third highest is the cuspids or the canines, and the fourth highest is the incisors. This is pretty easy if you just visualize it. And since there are no premolars in the deciduous teeth, this is how we can just think about it from back to front. Okay, starting from the back. But once we get to the permanent dentition, again, this is where it's going to be a little tricky. So the first highest incidence are the mandibular firsts, which are number 30 and 19. Then it's the maxillary first, which are teeth number 3 and number 14. Then is maxillary and mandibular seconds, which can be number 2, number 15, and number 31 and number 18. Okay. Then there's the fourth highest, which is the second premolars. Fifth highest, maxillary incisors, front teeth. Sixth highest, first premolars. Seventh highest, mandibular incisors, so the lower front teeth. And then the canines are the last. All right. So make sure we remember that. Also, surface incident ranking, mandibular first teeth on occlusal or buccal, maxillary first teeth on occlusal or mesial, maxillary lateral incisors or lingual. Okay. So before we go on to lecture number 6, dental trauma, I'm just going to do a quick review of this whole slide set just to make sure we got everything. So we understand the definition of the dental caries process, which is the localized post-eruptive pathological process of external origin involving destruction of hard tooth tissue. All right. The theories behind it started with W.D. Miller in 1890s, which is a chemico-parasitic theory. Then G.B. Black and J.L. Williams demonstrated the action of acids from bacteria. In 2017, we went from plaque to biofilm. Okay, that's good to know. Anthropological studies confirm relative scarcity of caries before the turn of the last millennium. Over the next 500 years, incidence increased with intro to dietary sugars. All right. We know that it's multifactorial. There are 3 principal factors: host, microorganism, substrate. The fourth is time. We need the susceptible host, cariogenic oral flora, and suitable substrate over a sufficient length of time. That's what the process requires. Make sure we understand that. All right. Good host, flora, and time, and substrate. Okay. All right. So you know that the host component is remineralization. We spoke all about all that. Cariogenic bacteria that I didn't talk about was also Streptococcus sobrinus. Okay. And the biofilm protects bacterial colonies in a cocoon of glucan, preventing them from being washed away from the antimicrobials in saliva or introducing the environment. So acidogenic bacteria must be present, and the acids produced must be prevented from washing away. All right, so again, remember that the early stage of adherence of Streptococcus mutans is the beginning. They produce extracellular glucans and found in large numbers in biofilm occurring over smooth surfaces. All right, so we talked about all that because then it goes from that to lactic acid and then to lactobacilli, yada, yada, yada. All right, so we're going to go now to dental trauma. All right. So for dental trauma, let's talk about that. We don't want to invade the supracrestal attachment. So that's why the way things crack are very important. Depending on how things fracture, that is how things are going to be treated. Most traumatized teeth are 82% of the time maxillary teeth. 70% of all dental injuries are usually involving the maxillary central incisors. So most traumatized teeth are 82% of the time maxillary teeth, but 70% of all dental injuries are maxillary central incisors. Males demonstrate a 2 to 3 to 1 ratio of fractures compared to women. So men have a 2 to 3 compared to 1 ratio. All right. Very important here. We need to understand the Ellis classification of crown fractures. Class 1 is enamel only. It can be an incisal chip in some cases. It can traumatize the tooth. So class 1 is small, doesn't require much, maybe just a filling. Class 2, then the dentin is exposed now, but there is no pulp exposure. It should be covered up still. That's a class 2. Class 3 is the pulp is now exposed, which bleeds and is painful. All right. Then there's also an oblique supragingival fracture, which is treatable without a pulp exposure. And then there's root fractures are more severe. But class 1, 2, and 3, 1 enamel only, 2 it's in the dentin, 3 pulp is exposed. All right. There's cracked tooth syndrome, which is sharp pain but no visible sign of problems. Clinically or radiographically, there's things called Caries lines. They're visible cracks in the enamel. They're painless, they're vertical, and mostly noticeable on front teeth. Common with possible explanation of differences in coefficient thermal expansion of enamel and dentin, more of an aesthetic concern. Now we're going to talk about luxation, subluxation, extrusion, lateral luxation, intrusion, and avulsion. All right, these are the ways that teeth can be traumatized from not that bad to very bad. So luxation means the physical trauma when a tooth is dislocated in the socket and but it maintains some attachment. That's what luxation means. All right. That's what luxation means. It maintains some attachment. Um, Now we're going to talk about subluxation, extrusion, lateral luxation, and intrusion. Subluxation is not that severe, with some mobility and bleeding from the gingival sulcus. Subluxation. All right, so subluxation meaning that there is some trauma, but not that much. Injury increases mobility, bleeding from the sulcus, but the tooth is not displaced. So again, subluxation is not as bad as the rest of them. Now we're getting into worse situations. Again, subluxation is like someone took a hit, but it's like the tooth is still there. All right. Now, extrusion. All right, this is now a partial displacement within the socket, partial or total separation of the PDL. The bone is intact, but it can be protruded or retrused. I mean, it could go forward or back when it's extruded. All right, so the tooth can lean forward out of the socket as far as the root leaning forward and the tooth going back more. Lingually, it is just kind of misplaced out of the socket a little bit from the root. All right, that's going to be extrusion. So again, extrusion is a partial displacement within the socket, bone is intact, protrusion or retrusion. Now we're going to talk about lateral luxations. Lateral luxation, this is a fracture of the labial or lingual alveolar plate. The apex is forced into the bone. This is when displacement of the tooth other than axially. So usually affects more than one tooth if both sides of the alveolar socket are fractured. There's no response to pulp vitality and has a disconnection of nutritional canals. And this is a very serious thing. When this happens, You must press it back into the position as well. But again, lateral luxation is bad. It's worse than extrusion. Extrusion meaning it kind of came out a little bit, but lateral luxation is now you broke one of the buccal or lingual plates. Most cases, apex is forced into the bone. There's a compression zone, radicular, cervical, apical area. If both sides of the socket, no response to pulp vitality test. So lateral luxation is pretty bad. I mean, you have to take it out probably at that point. Then we got intrusion. Intrusion is it's like getting hit on a tooth, but it's being pushed into the socket, into the alveolar bone. There's a fracture of the alveolar socket apical to the surrounding area. Intrusion, okay? It can be left alone, or it can be used, orthodontics can be used. That is intrusion, okay? So the tooth got pushed into the root. Apical to fracture of alveolar socket, apical to surrounding area. Then there's avulsion, which is the worst thing and the thing that we need to remember how to treat because this is going to be on the test. Avulsion is the tooth is completely displaced and comes out of the socket. It has to be reimplanted back into the socket as soon as possible unless it is a primary tooth. What we have to do is we have to grab the tooth by the crown, clean up the dirt and debris with saline solution or tap water to place back in. Again, at this time, we have to know where we're going. We're going to the dental office, not emergency room. If it cannot be placed back into place, then place it into milk or saline for best chance later. It must go to the dentist ASAP and not the emergency room. Do not use alcohol-based solutions that will kill the fibers. If it's been out and dry for more than an hour, then the prognosis is poor. But the sequence is to manage the tooth by the crown only, and then all loose dirt and debris should be gently rinsed away with normal saline solution or tap water. All right, and it has to be done as soon as possible. If it cannot be reimplanted, then place in Hank's balanced salt solution, milk, or saline. These solutions help protect hydrated nerves and periodontal ligament cells, thereby facilitating successful reimplantation at a later time. So teeth that have been out for more than an hour have a very poor prognosis again. And the frequency of avulsion from traumatic injury is 7 to 13% for primary dentition, 1 to 16% for permanent dentition. Also get a tetanus shot. Anyways, that's it. All right.